Yeah. The end of 2020 is the whoo, hoo, hoo. Can General Counsel please read us out of closed session?
Sure. The board considered 3 items in closed session this evening. The first was a hearing under Health and Safety Code 32155 for the first quarter fiscal year 2021 quality dashboard. There was no reportable action on that item. The second was approval of closed session minutes from November 19th, special meeting and regular meeting. And those were approved on a 5-0 vote as amended. And finally, there was a hearing on medical staff credentialing, and that was approved as well on a 5-0 vote.
David, we did not, I thought we voted on the quality dashboard.
Correct.
Okay.
That is correct.
Are there any deletions or corrections or any adjustments to the agenda for the meeting? Hearing none, I'll go to audience input. Martina, do we have any written or called in comments from the audience?
I have not received any public comment.
Is there anybody that's currently in the Zoom audience that wants to make comments? Hearing none, we'll close audience input. And we'll move to item 12, input from our Employees Association. Is there any input from the Employees Association? Anyone present or have called in? Okay, hearing none, we'll go ahead and close that item and move on to Safety First. And I think Jake Dorst, our CIO, is going to present Safety First.
Thank you very much, Chair Wong and board. Good evening. I'm Jake Dorst. I'm the Chief Information and Innovation Officer at Tahoe Forest Hospital. I wanted to give everyone just a brief heads up. I don't, it's kind of the story's been buried a little bit with all of the other important national news going on, but there's a pretty large ongoing hack going on of the United States, massive data breaches of multiple U.S. federal agencies, all stemming from malware that was implanted into a company called SolarWinds. And that has taken a lot of work trying to figure out on the federal side, what do they have command and control of, and what networks are they just in and able to look at data. So that is ongoing. We've taken steps internally to prevent those we don't use SolarWinds here. We demoed it 4 years ago. I've used it at other organizations. It's good software when it's not allowing hackers into your house. But I did remember we had an installation. We tried it out and we were able to go find it and removed it and make sure we were safe. It wasn't the version that's being used now. Orion is the one being used now. But our software is working. We had some malware get through, and what we call traps, which is the local on your machine antivirus, which recognized the package as being malicious and stopped it from installing. So our perimeter is working. We were able to shut that computer down and remove it from the network and quarantine it, so to speak. So we've got our own virus issues happening on the IT side. So this is happening. It's pretty widespread. The fact that it's not getting as much press right now, I think, is because, you know, the vaccine's coming out and there's still election shenanigans happening. So I think there's a lot of things that are on top of the news chain right now, but this is happening. So I wanted to let you know, we know about it. We are on top of it. We want to make sure for our safety of our patients that our systems are protected, intact, and available to our staff as much as we can possibly keep them available. So Questions? Yes, Mr. Chamberlain.
Is the motivation for these hacks strictly ransom money?
Some is. They're pretty sure that this is all coming from state-sponsored Russian hackers. I don't know why the U.S. doesn't field a team, but we probably, like, you know, the Chinese and Russian countries have employed hackers by the federal government going out and attacking other nation states. So I think a lot of it is just, you know, the disinformation that was 4 years ago to now where it's, you know, intellectual property, just destabilization as a whole benefits those countries.
So just to create havoc is that?
Pretty much.
Yeah.
Keep people like me employed.
Yeah.
And then with the holiday season, I don't know if the rest of you, I'm getting all kind of scams and, you know, just emails that you worry about opening them up and getting a virus. So again, it's for the safety and of the information at the hospital, but also personally, we have to take that into consideration as well.
Yeah, it's been bad. I'd say over the last 6 months, it has been really elevated. Apparently my credit card was used to buy an Apple iWatch in Florida yesterday.
Now you know your Christmas present, darn.
I'm getting snow in my shoes up here. I'm like, wait a minute. Not only do I miss the Florida, I don't get the Florida weather, but I also don't get to use the watch I bought. So yes, be diligent. We've informed the staff multiple times to watch out for odd or suspicious behavior. Our staff is actually very savvy. When we test them with we've talked about this before with the phishing emails, we usually do pretty good. There's not a high click rate. Well, it's lower than most. So that I'll take that as a win.
Absolutely good to hear. Any other comments or questions about?
Yeah, just another question, Jake.
Yes, sir.
We get a lot of emails from outside sources directed to our hospital address. And when you say don't open them, but again, as you click by them, that's not opening them, I take it. So,
That's not opening them. And if you're at home reading on like your iPad, it's not a threat to our network here.
oh, good. Okay.
So if you're using the client that's built into the iPad and it's downloaded to your iPad,
Right.
you're not really on our network at the hospital at that point.
I sometimes use my personal computer though as well.
Yeah.
Just to get your email, like the
My
webmail.
hospital email, correct?
Yeah, if you're not here on site and connected to the network, then you're not a threat.
Okay, thank you.
But yeah, opening like an attachment. For example, the name of the attachment that had that malware that we intercepted was called sample.exe, which is an executable file. Luckily, that person did not click on sample. And oh, what does this do? But people are curious. There's other ways that they do. Hackers will leave USB sticks in parking lots. So someone will pick them up, take them into the building, like, oh, what's on this? And that's another way for those to.
Oh, that's clever.
Yeah. They've thought of a lot of things.
Yeah, okay.
But yeah, if you're just checking on your phone or you're checking now, that could compromise your home network. So I would still, no matter where you are, I wouldn't open attachments that seem, especially if there's misspellings. There's certain things you can look for in the email, your name misspelled, or odd colloquialisms you may see. If you don't know that person, I would not just randomly open up attachments.
Yeah, my wife got one the other day, said free prize.
Yeah.
Click right here.
The free prize is we ruin your
All right. Well, thank you so much, Jake, for your information. And we will be aware, and it's good to hear that our staff is very savvy about looking at their emails and where they're coming from.
Yeah, we do a good job. Thank you
So,
very much. I appreciate your time.
Okay, we'll move on to
Yes,
item 14, acknowledgements. And we have Alex McClellan, our Chief of Human Resources. with our Employee of the Month.
Thank you. Yes, I'm super excited this month. As our final December Employee of the Month, we named Myra Tanner from our Environment of Care, or she's, excuse me, the Environment of Care Coordinator in Facilities Management. And I'm going to read a few things that her colleagues have said about her. Myra goes over and above in each and every interaction. She approaches each challenge in a collaborative way and does an incredible job. This summer, with the accreditation surveys and the pandemic, Myra has excelled in meeting every challenge in front of her. Another colleague boasted, Myra's dedication to the environment of care for TFHD is exemplary to all. Her work on COVID, HFAP, security, to whatever she's asked for is truly remarkable. She is a true asset to TFHD. So give it up for Myra Tanner.
Hey,
Congratulations, Myra.
Well
I'm sure-
deserved.
I'm sure she enjoyed the fact that she got it and it's the end of the year. So thank you again for providing that acknowledgement for us. And then in 14.2, we have the Employee of the Year. And Alex has handed it off to me to give. So I would like to announce to you, and it was announced at Town Hall on Tuesday, that Dan Dota is our 2020 Employee of the Year. And I'm not sure if Dan's here. We're going to try to get him. But Dan was our January 2020 Employee of the Month. And here's what some of his coworkers have said about him. Oh, before I go into that, I just wanted to let you know, he's been here for 10 years. And this isn't the first time he's gotten nominations. He's gotten them over the years. He was the January 2012 Employee of the Month. 8 years later, he was the January 2020 Employee of the Month. So 2 years he's been that. And his coworkers have these things to say about him. The first one starts off with, our shifts rarely cross over, but when they do, he always goes out of his way to see if there is anything he can do. Another one said, I cannot say enough good things about Dan. And still another one says, he is always smiling and whoever he interacts with ends up smiling too. Every time I see Dan, he's positive energy, is contagious. He has always gone out of his way to offer his help and has never expected anything in return. He lives our values every day. I'm honored to work with him and call him my teammate. And so that is the example of who we have working for us. Our Dan, who's the Employee of the Year for 2020, he not only got a plaque, which he received at the town hall, but he got a monetary award from Human Resources. Again, medical staff being so generous gave him an award as well that's monetary. He gets to have a gift of his choice from a catalog that's in Human Resources. And if we could only go in and out of the hospital, we'd see his picture in the lobby. So thank you so much to Dan for all that he's done in the 10 years that he has, and that he's an exemplary employee. Are there any comments or any additional comments you want to give on Dan, if anybody knows him? Okay, then we're going to move on to our next acknowledgement, and that's for the 2020 California Opioid Care Honor Roll program. And Mary Brown is going to be giving us that acknowledgement.
Yes. Say every day, more than 128 people in the United States die after overdosing on opioids. The misuse of and addiction to opioids, including prescription pain relievers, heroin, and synthetic opioids such as fentanyl, is a serious national crisis. In California, there were over 2,400 opioid overdose deaths. That's a hard one to say. 2,400 opioid overdose deaths in 2018, a 5% increase from the prior year, including over 780 deaths from fentanyl, a 72% increase. Hospitalization is a reachable moment for many people with opioid use disorder. to accelerate hospital progress in building systems to treat hospitalized patients with OUD and train healthcare professionals in opioid safety practices. Cal Hospital Compare supports the California Opioid Care Honor Roll program. The goal of the program is increased access to addiction treatment for hospitalized patients and reduction of opioid-related deaths. All California adult acute care hospitals were invited to participate, and 89 hospitals voluntarily submitted data sharing their progress on implementing evidence-based practices to address the crisis. The 80
I think Mary froze.
but reflect a diverse cross-section of all cross-section of all California hospitals across rural, urban, and academic settings. However, participation in this year's Opioid Care Honor Roll is a signal to California's healthcare community that all 89 hospitals are actively accelerating and strengthening their identifying and treating patients with OUD, overdose prevention, and applying cross-cutting opioid management best practices. The 2020 Opioid Care Honor Roll recognizes 2 tiers of performance: superior performance and excellent progress. Using this approach, 53 hospitals achieved the 2020 Opioid Care Honor Roll out of 89. 25 hospitals met superior performance criteria, and 28 additional hospitals met excellent progress criteria. Hospitals achieving superior performance of I'm sorry, Alice cut this down and I've been reading the whole thing. Anyway, I'll go on. Hospital superior performance have implemented advanced innovative stewardship strategies across the multiple service lines, consisting of achieving the highest level of performance. In addition, these hospitals are actively measuring and monitoring their performance and for the performance of quality. I'm not going to continue to read this. It's in your packet. Bless her heart, Alice did a cut and paste for a much reduced version, and I skipped it and went on to this. But we did receive the, we're mentioned in the honor roll for excellent progress, and this will go on into 2021 and hopefully be spread amongst more hospitals, and they plan on additional learning opportunities in the future. So my apologies for reading the whole thing that you have before you.
Good job, Bill.
Yeah, and it's our first year, I think, applying for the honor roll. And so we are in the company of some really good hospitals, but we do have some challenges ahead of us. And Carson Tahoe, no, it's Marshall. Marshall is one of our collaboratives, and they're on tier 1, the superior. So again, if we want to be competitive, we want to look at what those criteria are and see if we can improve our care for those who are, are using substance and have the opioid addiction. So thank you. And
Yeah,
congratulations, Tahoe Forest.
I was curious about what, just a few of the things are that we have done in terms of making progress against this issue, especially since everything that we're reading says that as soon as the COVID issue is dealt with, we have a huge opioid issue waiting right behind it.
Well, I know that they're looking at some of the best practices and that it has to go over multiple service lines. I know that right now we have, and Dr. Cole, you can jump in on this one, is that in the emergency department is probably where we have the most activity in some of these best practices. And that, I forget the name of it'll come to me. Where they're using substitutes for the opioids.
Program.
Yeah.
There's an extensive outpatient clinic that is doing it, and the emergency department refers patients to that clinic for like Suboxone treatment. Is that what you're talking about?
Yes. Yeah. And the education that happens too, you have to have that in place. And to be in that excellence tier. But again, it's that we are showing the world that we are trying to work on that in our community. So I think kudos to us.
Great.
Our item 15, Dr. Trudell is going to present the meeting consent agenda from the Medical Executive Committee.
Thank you, Chair Wong. And before I present the very brief consent agenda, for those of you who are not in closed session, because we did discuss this there, I'm just really happy to announce that this year the medical staff has donated $20,000 to a number of local charities. We tried to really spread it around and give good cheer. So it was really, really rewarding for all of us to do that. Moving on to the consent agenda. Thank you. We only have one item tonight. It's our trauma performance improvement plan. As you're aware, we are in the queue to become a level three trauma center. That was delayed because of COVID and lack of site visits. So we're currently level 4. However, we're still moving forward with the level 3 plan, and this process improvement plan is part of level 3. I'm sure Dale would ask. So yes, we are implementing this already, even though we're level 4. And it's a lengthy document. See, I'm getting to know you pretty well. It's a lengthy document. It really goes over all the aspects of data analysis, who's involved, roles of those who are involved, how we collect the data, how we analyze the data, how we compare it to national standards. If we come up short, how do we address that, and methods for process improvement. So this is approved by the MEC and recommended for approval by the board, unless you have questions about the document.
Are there any members of our board? Dale's question's already been answered, so.
Yeah, I've got a question. This is Art. So were there a lot of changes to this document, or is this a brand new document? I mean,
yeah, this was kind of integrated to our own facility. It's a template they worked off of. This wasn't written de novo, but it was certainly adjusted to apply to our facility with, naming the trauma medical director and the trauma program manager. Tongue twisted tonight. So yes, hopefully that answers your question.
well, it was very comprehensive. And so how often is there corrective actions? Because I know that was part of the document.
Yeah, it's a really good question, and I can't really answer that. For now, we haven't had any corrective actions because we're just getting this program rolling.
Okay.
Doing data collection. It'll be a good question to answer in a year or two.
Okay, all right, thank you.
Well, that's a point to bring up, Dr. Trudell, is because it doesn't sound like there's a real direct connection with the hospital or the health system's quality assurance program, but both programs come under the Medical Executive Committee. So is the information being shared between the two?
That's a great question. You guys
No, that committee reports to the Medical Staff Quality Assurance Committee.
Okay. So we would get, as a board member, we would get that information through board quality. Okay, thank you. Any other questions from our audience in regards to the credentialing? I'm sorry, to the consent agenda? Okay, hearing none, can I have a motion to approve the consent agenda regarding the trauma performance improvement plan?
So moved.
It's moved by Mary Brown.
Well, second, Michael.
Seconded by Michael McGarry. Could I have a roll vote, please?
Director McGarry?
Aye.
Director Shamblin?
Aye.
Director King?
Aye.
Director Brown?
Aye.
Director Wong?
Aye. So the motion carries and the trauma process improvement plan has been approved. I know that those of you who have not been in our closed session may not know that this is the end of Dr. Treadell's term as Chief of Staff. It means that he probably won't be coming to our meetings on a regular basis, but I do want to thank you, Dr. Treadell, for the contribution you have given to our board meetings and our health system in general. Your professionalism, your patience, it's been a privilege to work with you, and we wish you all the best in 2021. We know that 2020 has been very stressful, and you as a provider probably have carried a burden of that stress with the patients that you see and the questions that you're given. So thank you again for all the service you do, and we look forward to having cameo appearances from you once in a while.
Yes, I would be honored, and it truly has been an honor to serve in this role for the past year. The medical executive committee that I know Chair Wong has direct interaction, but the rest of you don't. They're just an amazingly thoughtful, diligent, committed group. There's nothing that they gloss over. They really put their heart and soul into everything we do, and I think having strong leadership, this is something that I've repeated over and over and over. I think strong leadership is really a key part of having a strong medical staff, which we do. And of course, we do appreciate the support that we've received from the board. And yeah, I'm kind of looking forward to riding off into the sunset, but certainly I'll ride my horse back. So thank you.
Well,
so much.
happy trails to you then, if you're riding off into the sunset.
Can you, Hawaiian shirt.
Wine shirt, yes.
Yeah. Okay, so we'll move on to item 16, the consent calendar. And on that, we have our minute meetings from 3 of our board meetings, 2 special and 1 regular, and then our finance report. Usually these are just reports. There's nothing very controversial about them, but certainly if any member of our board would like to pull any of them, or anybody from the audience for further information. So is anybody interested in pulling any of our items under the consent calendar?
No.
Yes, yay. So then can we have a vote to accept the consent calendar as presented?
So moved, Dale.
Second, Art.
So it's been moved and seconded to approve the consent calendar. Martina, will you please take the roll vote?
Director McGarry?
Aye.
Director Shamblin?
Aye.
Director King?
Aye.
Director Brown?
Aye.
Director Wong?
Aye. So the calendar has been approved. We'll move on to item 17. Our first item is the 2020 Cancer Center Quality Report. And we have Dr. Kamen and Kelly Botley, who will be presenting the report.
Good evening, Chair, and good evening, directors. Martina is going to pull up my slides. Can you see? There we go. This is always a positive report, and I'm happy to present this to you at the last meeting of the year that leaves the year on a very positive note. I'd like to acknowledge Kelly Bottomley, who is my partner in crime to develop our quality programs. So a couple of just top level things. Here's some of our milestones. This is the number of new patients that come into the Cancer Center over the years. You can see on the far right, there's a little dip, and that's partly because of COVID, and we'll talk a little bit more about that. Next slide. With the growth of patients also comes growth of personnel. So these are all of the people who joined the Cancer Center physician-wise over time. As Dr. Katie Lagarza joined us as our new radiation oncologist, you may recall that Dr. Heifetz and Dr. Palmer retired at the same time, June of 2019. Dr. Lagarza, when she saw these slides, she remarked, "Oh no, they're going to think because I came on board, we had less patients." And just is not true. I will show you in another slide, drill down on the numbers in that. So as we increase in patients and personnel, we also increase in the breadth of our quality initiatives. Next slide. And this just shows in kind of a snapshot form all the quality programs that we have been doing over the years. Starting with, you first have to have a cancer registry. You have to have a platform on which you start measuring all the care you're giving. Our first was American College of Surgeons, or Commission on Cancer. That's the other name for that, accreditation. That was very important in 2011. We've been reaccredited twice with that organization with distinction. We've had all sorts of other certifications that I will walk through. All of this I understand is word salad, just a bunch of capital letters. So I will talk a little bit about each of these because it's important to understand that we do many, many things here. Next slide. And so this is just a little drill down on the numbers. You know, sometimes fiscal years here don't match up with annual years. So sometimes things get kind of lost in the translation between the two. But these are the number of radiation treatments over the last several years. And you can see that after Katie Lagarza got here, we actually increased dramatically the number of treatments we were providing in our radiation suite. So it's just remarkable. So it's our numbers, if anything, are up because of her. Next slide. So all of us know that this year has been a banner year for so many different things. And so as you all know, what you may not know, that in March 3rd, we converted to Epic here in the Cancer Center. And so last year I said you cannot overestimate the impact of that transition. I will say that again. We are still living through that transition even now. So that happened right about here on the left-hand side of the graph. And then COVID hit, right? And everything shut down, except for the Cancer Center. We did not shut down. And so we quickly transitioned in several different ways to still accommodate patients. The cancers didn't go away. The treatment still needed to be given. The patients still needed to be seen. And so we did that in one smart way by doing a lot of televisits. And that's the red curve and the red bars there. And you can see that we went from virtually 0 in week 10 to over 50 by week 15. And so that means we do a televisit with the patient or just a telephone call if they don't have those capabilities. As you know, we've been doing telemedicine for many, many years, but this is different. Telemedicine has a nurse practitioner in the room on the other side at a medical center, whereas a televisit is just we on this side and the patient on that side. So you can see we totally ramped up as appropriate to still take care of these patients through these months. Next slide. So what did we do to continue giving care to these very vulnerable patients, even with COVID? There were no treatments that were omitted or delayed because of COVID. We were an early adopter of lots of safety measures. And one of the things we did was the telehealth, as I mentioned to you. We did virtual visits also for even clinical psychology and our nursing education. Every patient going through chemotherapy gets a whole host of educational sessions. And so we did that virtually. I have to mention one person in particular who made this so easy. I mean, we were busy seeing patients and tried to figure things out. And the person in the background that did the technology for us helped us to flip so easily and quickly was Amber Munson. She's an Epic consultant. She knows Epic better than anybody in the world because she's worked with Epic programs all over the country. So she was instrumental in keeping us going. We had careful symptom monitoring of everybody entering the Cancer Center. We limited our visitors to only those essential caregivers. We had strict adherence to masks and goggles. We wore scrubs for months and months. We went to Zoom-based meetings. As you know, in the Cancer Center, we huddle all the time. Communication is so important. And so to maintain that communication, we did it by Zoom. We opened our infusion room 7 days a week to help support the hospital surge plan. And I would have to say a positive attitude goes a long way. All right, next slide. So that's what we did for COVID. So I think we served the community well. So here's some of our accreditations, and I want to just tell you a little bit about them. The biggest one is the top one, the American College of Surgeons Commission on Cancer. That's critical for any cancer center, and we've been compliant in that since 2011. The next big one I would say is the American Society of Clinical Oncology, which is ASCO. That's like the AMA. But for a cancer physician, our parent overseeing quality organization is ASCO. and they've developed something called COPE, and we will look at that a little bit more later on. We've been certified in COPE. All of these are entirely voluntary. Nobody tells us we have to do this. We just on our own initiate these accreditations. We are also within the field of radiation oncology, ASTRO accredited. Then we are also within the area of lung cancer. We are part of the Adario Lung Cancer Foundation Center of Excellence. We also have implemented with ASCO something called Cancer Link, and that is something I initiated back in 2017, and we'll talk more about that. And then the last one there is because we want to be certified as a breast cancer center, we are in the process of applying for NAPBC, that's the National Accreditation Program for Breast Centers. That's been delayed because of COVID. So next slide, please. So each of these is a way for us to just assess our own metrics, our own quality, our own way of doing things compared to national standards. Many of these programs, those standards are assessed for us in a way that we cannot manipulate the data. We're all for that, right? We're not trying to cheat on anything. And so it just measures us against other cancer centers in California or the United States. We also, within our quality programs, we identify issues that we would want to shine a light on or just evaluate, and you'll see some of those examples later on. So we are continually looking at things in real time. It's not just what other people have asked us to do, it's what we say, hey, are we doing this well? And we go look at it. So let me walk through, next slide, please. A few more. So the Commission on Cancer, that's the big one, the one that we've been accredited since 2011. That elements that were tested are from the Commission on Cancer, the National Quality Forum, from CMS. These measures are used to assess our quality of care. They can be used to assign whether or not an insurance company will allow a patient to be seen here. We prove that we provide quality care, so insurance companies are more likely to say we are going to be an in-network organization for their patients. There's some quality improvement and measures that are not used for financial reasons, but just for internal monitoring. The Cancer Committee, which I chair, annually assesses and monitors these measure outcomes. Next slide. So there's 20 different quality measures in the Commission on Cancer. And so I've listed some of the diseases we look at there. We're going to look at our breast cancer measures. There's 6 of those. Breast cancer by volume is our #1 disease here in the Cancer Center. So we see far more breast cancer patients than any other disease here in the Cancer Center. So next slide. These, and next slide. These are the 6 quality measures that we are assessed with. And you can see, so one is radiation therapy. Do we give it to women under the age of 70 who have had a lumpectomy? Do we give chemotherapy appropriately? Do we give other treatments like hormonal therapy appropriately? Do we give radiation appropriately to women who have lots of positive lymph nodes with their breast cancer? How do we diagnose it? Is it by stereotactic biopsy? And do we offer breast conservation surgery as compared to mastectomy for the appropriate women? And you can see we've got a huge problem. We're at 100% down.
Yep.
So, and you can see we're compared to California and to a national program. So it doesn't get much better than this. And you'll see that this is for 2017. All this data gets reported to a central repository, the National Cancer Database. And then we got this information back from them just a few months ago. So just so you know, there's a lag time between the data we submit and the reports we get back, but we are at 100%. We don't expect to be any less than that.
And one thing I want to say quickly is that doesn't happen in very many programs. I've worked with lots of programs throughout the country, and that very rarely happens.
Yeah, so you can be proud. I mentioned COPE, that's Quality Oncology Practice Initiative. So that's another quality program that instead of just 20 different measures, there's up to 195 different quality measures that really drills down to everything we do in cancer care. So we voluntarily signed up for this program in 2016, and it meant abstracting from charts and sending in data, which was a lot of work, but I did that in 2016, 17, and 18, and you can see our scores there. In 2019, we worked with ASCO to, because we had this other functionality called Cancer Link, which kind of looks at our electronic medical record and is able to sweep from our electronic medical record. So I didn't have to do any chart abstraction. They just swept our medical record and assessed our compliance with all these measures. It was a pilot program. We were one of 5 sites in the country that looked at this way of measuring things. And even though the score is 86%, the way they machinate that score, it's a math equation that is actually quite challenging. I will tell you, when we met with these people and we said, wait a minute, we're not an 86% kind of cancer center. What did we do wrong? And they said, no, you are essentially the highest scoring cancer center in the country. So the 86% is good, even though for those of us that are overachievers, it feels strange, but we're fine. Next slide, please. Okay, so Cancer Link is a way it's a program that we put on top of the electronic medical record, and it automatically then pulls out data. And so I can say, how many left-handed breast cancer patients did I see in March of 2016 compared to the nation? Or, you know, if I gave this drug, how did it do for my patient compared to the rest of the nation? So we can slice and dice the data in ways never ever before possible. So it gives us insights. When you have all that data, you can compare things that you don't typically compare, right? Like, how often is a smoker going to have a bad outcome related to their chemotherapy because of their smoking? You know, so you can assess all sorts of things. So we adopted that many years ago. Next slide. And but remember, in February 2020, we transitioned from our old electronic medical record that we were using CancerLink with to Epic. So CancerLink now has to map everything again in Epic. So it's a monumental task. And even if they started way back in the spring, we're not done. I've got to say, sometimes it's our vendor is not always coming to the table as they should. That's all I'm going to say as diplomatically as I can. CancerLink is working very, very hard with Epic to make this a functional for us. So next slide. Okay, so what do we want to look at, right? So those are the national ones where we don't get to choose what measure we're going to be assessed on. We get to look at our own program and ask questions. How are we doing in this regard? So one question we had was, how are we documenting if a woman is pregnant before she gets radiation therapy, right? You don't want to radiate a pregnant woman. Same way with chemotherapy. If a woman is premenopausal, how are we making sure we are not giving chemotherapy to, you know, a pregnant woman? And so we assessed that. We developed a policy and procedure manual for radiation oncology, and we're testing the process in radiation oncology now, and then we'll extend it over to the medical oncology side. We talked about our efforts to accommodate COVID, and I'll tell you a little bit more how we've done that. We'll talk a little bit more about Epic and what we've done to accommodate Epic. And then we'll talk about some clinical studies that we've done that is just, we intrinsically have curiosity as to how we're doing. Next slide. So one of the things that we did with COVID is, because we have a clinical research program here in the Cancer Center, and we're the only department within the district that has a cancer focus or cancer capabilities, that we have all the machinery in place to do clinical trials. We partnered in a couple of different ways to do clinical research in the era of COVID. So one was evaluating the expanded access to convalescent plasma. And so we partnered with the Mayo Clinic and the FDA to, before it got approved, to be able to get the convalescent plasma here to our patients. So that was huge. That was part of a clinical trial. These patients would never have gotten it had we not been part of that clinical trial. It's since been approved for emergency use in August 23rd, but before then, that was the only way these patients got it, was through our clinical trial. And then we participated in a registry as well. So our parent, our AMA, so to speak, ASCO wanted to ask and have a registry is, how do cancer patients do in the era of COVID? So we're submitting all of our data on any of our cancer patients that are diagnosed with COVID. So I will say in that registry of all the cancer centers in the United States, only 39 are participating. We're one of those 39. So next slide, please. And this just showed the number of patients you can see in orange there who received the convalescent plasma through the clinical trial. That was the only way they would be able to get this convalescent plasma. And then it also shows in blue the number of our cancer patients that have been diagnosed with COVID. And that number is growing. Obviously, in December, that number will be higher. Next slide, please. EPIC. So in order to have EPIC work for us and to give chemotherapy safely, we have to use this new electronic medical record. It meant that it took a year for us to get ready for that, to implement 218 different chemotherapy protocols. And it's not just, let's give this drug, it's this drug, and what labs do you want with that, doctor? How fast should we give that drug? Are there any emergency drugs we need to have on standby in case something goes wrong? And all those other things that go with not just giving the drug, but every detail there is on giving that drug safely had to be built. We had lots of non-oncology infusion therapy plans. So we give lots of drugs by vein that is not chemotherapy, but still requires, time and attention. Lots of different workflows developed and approved for all the different things we do here in the Cancer Center. Telemedicine, we integrated nurse navigation. How do you bill for research now in this new electronic medical record? We had to work with the vendor. That was not something they were used to doing. So we had to kind of walk them through that. And then the next biggest thing is that we had to teach them how we give radiation. The vendor we used had never built EPIC for radiation oncology, had never done it. And so we took them from ground zero to build EPIC to accommodate all of our radiation oncology work. And so again, as I said last year, the impact of initiating EPIC within our cancer cannot be overemphasized. Mm-hmm. Next slide. Okay, so some clinical trials that we're curious people. We wanted to know, well, in lung cancer, it's one of the fastest moving cancers in terms of research. In order to better define the disease we're treating, lung cancer, it's not just one cancer, it's many. And depending on the personality of that tumor will dictate what kind of therapy you're going to be giving. And so all these new developments, we wanted to ask ourselves, are we keeping up with all this new research in lung cancer? So we assessed for appropriate staging. When is the right time to use a PET CT with diagnostic imaging and staging, pathological testing, molecular profiling? Almost everybody with lung cancer is not just, oh yeah, you have adenocarcinoma, but, and tell me more. We need to know all the mutations that are in that tumor that is going to guide our therapy. Also, are we referring to palliative care appropriately as we should? So we tested our 15 patients that were diagnosed with lung cancer in 2019, and we found that our care was appropriate for all these patients assessed. And I can give you that detailed report if you would like. You're welcome to review it. And then we looked at, do we do appropriate testing for patients with pancreatic cancer? Most recently, it was recommended that every patient with pancreatic cancer get genetic testing. Did you inherit a mutation that is going to influence the care you get for your pancreatic cancer? And so these were brand new guidelines. And so we assessed all the patients we had seen with pancreatic cancer, and we found that yes, our testing was appropriate. And again, if you would like that detailed report, I'm happy to share it. we're winding down. And then other clinical studies, I got to give a shout out. You know, we are very data driven here, and in Cancer Committee, we're very inclusive. It's a very multidisciplinary kind of group. And one of the important areas in our cancer patients is their nutrition, right? As you might imagine. And so we invited our nutrition colleagues to ask them what aspects of cancer care, where do we meet? What are the most important needs? And we can see that we lean on our nutritionists a lot. They've had to increase their work hours here to the cancer center quite a bit. We've increased our workload quite a bit over time. The most important aspect is who needs a feeding tube, who can't eat the normal way, and we've got to give them nutrition through a tube we put into their stomach or their small bowel. That's a feeding tube. And so when we do that, they're obviously usually way behind the 8 ball calorie wise. And how are we doing? How is that working out? So there were 9 patients that needed a feeding tube. And to reach their weight goal, 6 of them got to their goal in 6 days or less. And what kept the others from not reaching their goal? It was whether or not they had a caregiver. And I'll show you a slide that shows that. And then when you put in that feeding tube is important too. So I will tell you, some of our patients, especially that have a head and neck cancer, like a cancer of the tonsil, and they're going to get chemotherapy and they're going to get radiation. And I'm going to tell them at about week 3, you're not going to be even to swallow your own spit. You are going to walk around with a cup because you can't even swallow your own saliva. So you're going to have a feeding tube. And some patients say, nah, doc, you know, I don't want to do that. And so we say, okay. And they're fine for the first 2 weeks. And by week 3, yep, they need a feeding tube, right? It's kind of like I told you. And so what happens if we wait until they're in their treatment, till they get their feeding tube? So next slide, please. So the first one was whether or not you had a caregiver. And so if you had a caregiver that was involved, you were likely to gain 6 pounds versus if you didn't have a caregiver, you were going to lose 17 pounds. And so I think it's just a very elegant way. We all know it takes a village, but boy, it sure takes a caregiver here when you need a feeding tube. So I just thought that was a very elegant study that our nutrition colleagues did. And then the next slide. Oh, okay. So I don't have the slide, but you did much better if you got your feeding tube before you thought you ever needed it. Okay, our nurses have been obviously shoulder to shoulder with us throughout all of this. And so in the last year, we've built up a robust, dedicated breast nurse navigation system. So our nurse navigator actually goes over and meets the patient when she gets her breast biopsy, and then is with her even long before she is ever seen in the cancer center to make sure we have coordination of care. We developed a very formal, robust triage nurse program. And in fact, COPE looked at that and said, you guys, we need to duplicate what you're doing across the country. We work with a wellness neighborhood to have a promontoria. So we have a live translator in the room with us for our Spanish-speaking patients. We now work with urology for those patients that need chemotherapy instilled into their bladder. We help the urologist do that. 100% of our chemotherapy nurses have a certification through Oncology Nursing Society, and half of them have a certification through the Oncology Certified Nurse designation. So they're really on the ball. Next slide, please. And so I'll circle back to all of our formal accreditations, and I've listed all of them. We're accredited in all 5 of these. And I think it's pretty remarkable that a cancer center in a teeny tiny mountain town of 16,000 people has all these accreditations. And so can I take any questions?
Wow.
Thank you so much for that presentation. You had something, someone had, Dale.
Melissa, how has our continuing relationship with UC Davis aided us in getting these accreditations?
So it helps in many ways. So UC Davis is kind of our hub for clinical trials. They provide a lot of the personnel and infrastructure for us to be able to do clinical trials. doing clinical trials is a metric we have to meet for COC accreditation.
Okay. You made a statement tonight that I hadn't realized in the past, is that these accreditations help us get insurance companies to recognize us as in network. And that's got to be a huge benefit monetarily to us.
Dale, I honestly can't speak to what negotiations go on behind the scenes, for saying we're in network for patients or not. So I don't know how the rubber meets the road in that regard.
Yeah, okay. And one last quick question. What is the proven efficacy of this convalescent plasma? I've heard this on the news too, and I'm just curious.
I have not done the research to be able to give you that answer. So I'm not going to try to fudge an answer for you. I don't know the science behind that.
Okay, but it is going on still at Tahoe Forest?
Mm-hmm. Yes, it is.
Oh, great. Okay.
And the one thing I will say about the accreditations is, while it may be voluntary, it turns out that across the country, 84% of people with cancer get their treatment at an accredited facility. So they find their way to the best practice.
Yeah, good point.
Art?
Yeah, I've got a question. So where are our patients coming from now?
So we have, I don't have the exact numbers at my fingertips for right now, but over the years, our in-migration has been over 50%. So we have in-migration from as far north as Greenville, Fallon, Nevada to the east, Sacramento to the west, Mammoth to the south, all of South Lake Tahoe. So we have a lot of patients from Reno that come here.
Good. That's what we were hoping.
Yeah.
Michael? Michael, you're muted.
Sorry, my dog was barking earlier. Art, I had the same question, but it was actually tied to a quick story. And that's a good friend of mine put up a good fight against cancer about 20 years ago and thought he had won. It showed up again this year. And he moved up here full time to receive treatment at this cancer center. He was down in the Bay Area, and he was so impressed with his initial meeting with the team. There were some other contributing factors, but he basically said, "This is where I need to be." He was so impressed. So I think it speaks to that in-migration of people that not only is the reputation out there, but then the reputation is well lived up to once people step foot inside the cancer center. So thank you for all you do.
Thank you.
And Dr. Kame, the thing as a nurse that I really have appreciated in your report is the research and the research the nutritionists are doing. I mean, that makes a difference in the care that we day by day give patients. And that's the kind of research I am so excited about. And I hope that that kind of research kind of spreads throughout the organization. So thank you for that.
Thank you.
Any other comments from our board?
Good
Are there
report.
any comments from the audience? Well, that was a report. It was only for discussion reasons. And so we thank you again, Dr. Kamen. Wish you the best in 2021.
Thank you so much.
Thank you, Kelly.
Oh yes, Kelly too. I'm sorry, miss you. Then we'll move on to item 17.2, our legislative update by Ted Owens, who's our Executive Director of Governance and Business Development. Ted, take it away.
Good evening, Chair Wong, directors. Rather than a legislative update, because right now it's in the beginning of new sessions, that's a bowl of sausage mush right now. We don't know what's going to emerge. I'm going to give you a little bit of an update on new laws that will impact our organization as well as our industry. When I first did my run through this afternoon, I finished at a cool 42 minutes. So what I'm going to do is go much quicker. And if you want to take a dive with me on some of these items, I'd be happy to do so offline. So I'll hit the high points. The first item of interest is Assembly Bill 890, which is a Wood bill. Dr. Wood is a dentist from the North State. This is a piece of legislation that was signed into law respecting nurse practitioners. And commencing on January 1st of 2023, it allows NPs to practice who meet the educational and experience requirements to practice without physician supervision as specified in the law. Requirements for NPs would be a completed transition to practice in California, a minimum of 3 full-time equivalent years of practice or 4,600 hours, passing a National Nurse Practitioner Board certification examination, holding a certification as a nurse practitioner from a national certifying body, and can provide documentation that educational training was consistent with standards established by the board. This bill was controversial, as you can imagine. It has a lot of technical requirements on nurse practitioners, which is why it won't begin until January 1st of 2023. I know that Dr. Cole has had some concerns with legislation such as this, but I will tell you that the driving force behind it had an awful lot to do with rural environments and the shortage of providers, of physicians in the rural environments. And so this was an attempt to try to bring access to care and spread it through more of the rural parts of California. Again, that's Assembly Bill 890. If you want to learn more about it, I'd be pleased to go into it with you offline. We have some workforce bills of note, 2 that I'll share with you tonight. One was Assembly Bill 2288, a low bill on nursing programs during the state of emergency. This is a COVID generated piece of legislation. It allows nursing programs to revise clinical experience requirements for enrolled students until the end of the 2020-21 academic year, or whenever the governor states or declares a state of emergency, as Governor Newsom has done for COVID. There's also a follow-up bill, which is I'll get to in a moment. But yes, I thought I heard a question. This is would provide approved programs allowing nursing students to achieve direct patient care hours in specified amounts outside of the clinical setting. Normal clinical settings for nurses in education are limited because of COVID. So this is a way to help keep their education going, providing them different avenues when a state of emergency is declared. Also, Senate Bill 1237, a Dodd bill, speaks to nurse midwives, and this is similar to the nurse practitioners law in that it establishes criteria and allows certified nurse midwives to practice nurse midwifery for low-risk pregnancies without a physician or surgeon supervision. It is very definitive in the environment in which they can practice, but it does authorize the Registered Nursing Board 5 different criteria that they must apply that would allow for midwives to practice in this type of a lower risk environment. Assembly Bill 685 is a REIA's bill, and this is employee notices. Now, before I go too deeply into this, I would like to point out that we as a healthcare system are in an exemption status on this. So this applies to the outside world businesses. It establishes new reporting and notification requirements of employees by the employer when an exposure takes place. So yes, this is another COVID-driven new law. If an employer is noticed of an exposure to COVID-19, it must take the following actions, and I won't go through them in great detail, but provision of a written notice to all employees and subcontracted employees who were on the premise at the time of the work site when there was a COVID-19 positive that took place. Provide written notice to exclusive representative of employees as described above. If there is no employee representative, the provision doesn't apply. And provide all employees who may have been exposed and exclusive representative with information regarding COVID-19 related benefits to which the employee may be entitled. And to provide notice to all employees and contracted employees, exclusive representatives on the disinfection and safety plan that the employer plans to implement. The employer must keep a record of all these notifications for a period of at least 3 years. And as I said, There are qualifying individuals that are related in this. I can go into that with you at another time. Also definitions of what a work site is. So it does apply to a building, a store, to field work, to contractor sites and construction sites. The exemption, again, so we're clear, are employees of all health facilities and those employees who, as a part of their duties, conduct COVID-19 testing or screening or provide direct patient care. It also applies to employees that work in the building that may have been exposed to COVID through other means other than direct care, such as janitorial and what have you. This is a bill that is in place. It will sunset eventually when COVID is over, but this is something that we should share with the broader community, the Chambers of Commerce, the NLTRA over at the lake, because it's important for businesses to know that this is, in fact, in effect. Of course, there are some workers' compensation laws that have changed. Alex, I'm sure, is aware of this, Senate Bill 1159. This codifies the governor's executive order, which he signed in May of this year, again related to COVID-19. And it establishes a workers' compensation presumption for COVID-19 for essential workers during the pandemic. It basically is a door that opens to workers' compensation benefits through the contraction of COVID-19 in the performance of their jobs. It does have, it does establish a rebuttable presumption for COVID-19 for all other employees and places of employment that are not covered by the above presumption. For example, if there is an outbreak or a specific place of employment where COVID is contracted, or employee that's tested positive, and requirements for measuring and keeping all of the data related to that. This is a bill that will impact all businesses respective of COVID. It does sunset on January 1st of 2023, anticipating that COVID-19 will have run its course. Hold on just a second. I think I covered it. I was looking for an exemption, but I'm not finding it. Again, I'll take a deeper dive with you if you would like to do so after tonight. We also have a couple of bills. These two are really interesting to follow. I know Crystal was following these. They have to do with personal protection equipment and protective equipment. We had one in the Assembly called 2537, a Rodriguez bill that was running. And then later, Senator Pan introduced Senate Bill 275. And Senator Pan, of course, is a provider. He's a physician. The first bill that came out will require us, healthcare system, to report by April 1st, 2021, by January 15th, what our use of protective PPE was throughout the year of 2020 related to COVID-19. Out of that, by April 1st, we will maintain a stockpile of PPE equivalent to a COVID high level that we experienced of 90 days of PPE. Now, the governor signed this bill, and that's interesting because the other bill, SB 275, would require that we maintain a 45-day inventory, not a 90-day inventory. So he signed both bills. We are going to be applied by AB 2537 first for a period of time with the 3-month stockpile. It will also create a commission that will monitor PPE both at the state level, county level, and for healthcare systems such as ourselves. And then this will eventually be amended to sunset by January 1st of 2023 when the PAN bill goes into effect, which basically reduces the amount of PPE that we are required to maintain. I found it fascinating that they would run two bills concurrently that have two different sets of requirements and then have both signed into law, but that is how it happened. And, you know, sometimes, I don't know, it's a head scratcher, but nevertheless, we will comply.
Ted, this This is Art. I've got a question. So is that a state stockpile, or is that just all of the PPE throughout the state that everybody has?
It refers to both. So there are requirements upon the state, both to stockpile PPE and to provide a commission that will oversee those stockpiles and the stockpiles that we're required to have. So there's state stockpiles. We will be required to have our own on site.
In addition, okay.
This will be a bit of a challenge. We've got to determine space and where we can safely store it. And these are PPE that are brand new, never previously used or been cleaned or remanufactured. So it's quite a stockpile.
Yeah, okay, thank you.
Assembly Bill, how am I doing? I'm at 11 minutes and 40 seconds. Okay.
You're doing great.
Okay, not the last one you'll be really interested in. 1710, also a Wood bill. This is pharmacy practices, also a COVID-19 bill that was signed into law. And this authorizes a pharmacist to independently initiate and administer any COVID-19 vaccines that are approved by the FDA. There are requirements that the pharmacist must meet to initiate and administer. Those are listed, but this bill would enable CVS, Rite Aid, our own pharmacy to administer COVID-19 vaccine at some point in time when maybe that's appropriate. So we will see and watch that. Now the last one, and I'm looking, where's David? There he is. This is one that I think might come back in a retreat or in an educational format for a little bit of a deeper discussion. But AB 992 is a Mullen bill, and it's respective of social media. And it clarifies the kind of communications that public officials such as yourself can engage in on social media. And it identifies the kind of communications that you cannot conduct on social media because you are an elected official. Many of the things that tie that together, you're well aware of through your Brown Act training. For example, you can't have an ongoing social media discussion about an actionable item that is before the board. And it even goes so far as to include use of emojis that might send particular types of messages over social media. We can go deeper into this. I'll be talking to Mr. Ruderman about this, but I think we'll be talking about this at another date.
You should have received a memorandum also from our office about this bill. And if you didn't, let me know and I'll get that to you. This law goes into effect January 1 of 2021.
I knew you would know. And I will check tomorrow, and I probably have seen that earlier. With that, I thought I would stop at 14 minutes. If you have any topical questions, be happy to answer them. And if you would like a deeper dive into any of these, more than happy. Trust me, I have the data. It's fun to read.
Okay. Is anybody really wanting to read some more, or any questions for
You
Ted
run
to
out of your
entertain?
Lunesta. It's a good substitute.
Right.
Okay, I do have a question. On the workers' comp, if somebody gets COVID virus, are they eligible for workers' comp? Did I hear you say that?
They are eligible to some workers' compensation benefits. The exemptions that we have are our employees that it is the course of their duty to treat COVID-19 are exempt.
Okay.
But if you are working in a restaurant, if you're working at the lumber yard, if you're working in a hotel, employees, if they contract COVID-19 on the workplace, do have a presumptive right to workers' compensation benefits.
Okay.
How do they confirm that presumption?
The employer is required to make a determination of when the test is done, when they determined that they are COVID positive, and then working with tracers to go back and try to determine where in the workplace they were so many days back. Who did they work with? What team did they work with? And in what specific location did they work? Then there's also the requirements to notify the other employees of that situation as well.
But they also could have picked it up at the grocery store.
Well, Dale, I used to do safety checks on Monday morning to see who really got hurt snowboarding on the weekend.
I know. I know. What do they say? 60% of all workers' comp claims are filed on a Monday.
What they say.
But it is a presumption, so it could be rebutted if there was evidence to show that, in fact, the person was at some super spreader event and that's the only place they could have gotten it or something.
Yeah, okay.
Thank you.
And Ted, I thought AB 890 and AB 2288 were very interesting. One of them, as far as the nurse practitioners go and working without a physician overseeing them, I think all of the advanced practice practitioners, or I forget their terms now, but nurse practitioners and PAs, and even dental hygienists they want them to keep moving up to the maximum of their license because of all the shortages in healthcare. So I don't see that as a detriment, and I wish it would happen sooner, but I understand the technicalities to go through in order for the board to have all the criteria put in place. My concern in 2288 is just how the healthcare programs have fast tracked, and so, like the physicians from med school and the nurses, when they take their licensing exam, it's a proof of safety. So certainly they're safe to practice, but are they at the level that we want them to be practicing in our hospital or other places? So I think there's a double-edged sword to moving the nursing students through using other clinical experiences without supervision under an instructor. And that's just my opinion.
Well, your opinion actually was shared in the opposition documents and the bill analysis quite clearly. But on the other hand, they were, the proponents were trying to be proactive to keep people actually in the nursing programs and moving forward, as you put it. You described both sides of the argument on that one.
Any other questions about some of this legislative bills that Ted has presented? Okay. If not, thank you so much for that information. And
Thanks,
we'll
Ted.
be looking forward to hearing what happens with this new Assembly and Senate that we have.
Well, it's going to be interesting. As you know, both the houses are super majorities still.
Yeah.
In fact, I mean, the kind of a diminishing number of Republicans in both houses. I think there are 17 in the Assembly out of 80, and I believe there are maybe 11 out of 40 in the Senate. So we will see.
Okay. And with that, we'll end the discussion of the legislative update and go on to the COVID-19 update, in which we hope we hear some good news coming from either Harry, are you starting it, or is Judy?
Right. Good evening, Chair and members of the Board of Directors. Happy to provide you a brief update this evening. We commonly reference the pandemic as a period from March to the present, and so that's the main time frame, but it probably goes back even to December based on some of the earliest cases. But if we just use the March time frame going forward, basically for about the first 8 months or so of this pandemic, we saw some ups and downs, but one level of energy. And now what we've seen in the last 4 weeks around the world, around the United States, in Nevada and in California, a significant uptick in positive lab tests, hospitalizations, and so forth. The rate of increase in positive lab tests is very different than the rate of increase in hospitalizations as well, and the rate of deaths has its own track. So there's 3 very different tracks: the rate of increase of lab tests, the rate of increase in hospitalizations, and separately the rate of increase in deaths. What we have seen around the world right now, we have 75 million positive lab tests. The United States has 23% of those at roughly 17.5 million positive lab tests. 227 million total tests have been done to date. What we have seen in the United States, California, and Nevada, that the increase in lab tests is probably about 5 to 7 times faster per week over the last 4 weeks than it was during that first 8 months. So a significant increase there. What we have seen locally here in Tahoe Forest is our inpatient hospitalizations. As we've graphed it since the beginning, we can see each of the causal periods, but we've seen probably about a 2.5 times increase in inpatient census over the last 4.5 weeks or so as well. So not the same increase as lab tests, but certainly a significant increase. For example, out of the last 8 days, our ICU has had a 94% occupancy rate. That doesn't mean that it's 94% occupied by COVID patients. That's all patients, non-COVID and COVID. So one of the key indicators that's being looked at all around California is our hospitals maintaining 85% or less inpatient occupancy in their ICU units. And so we're certainly running higher than that, at least in the last few days. So our team has been very busy. They're very courageous. I'm proud of them. I think we have pretty much all the important modalities. The thing that's really special about this week represents really for us part B of this 9.5 month journey that we're in. And that part B is really memorialized by the start of, guess what? The ability to start on a very small basis vaccinations, following a series of criteria by state and local officials. So I will shut it off there, and Judy has some great information to share about vaccines.
Thank you, Board of Directors. And I do want to mention that following me, Dr. Cole, our Chief Medical Officer, will give a little bit more detailed information regarding the vaccine Pfizer itself. So we do recognize that there's been a lot of information about release of information about the first COVID-19 vaccine, and I know that yourselves and the community have a lot of questions. So we'll try to provide you the most latest information that we have. So the COVID vaccine actually has 4 phases: phase 1, phase 2, phase 3, phase 4. And actually phase 1 has 2 tiers in it, 1A and 1B. And currently, the United States is really focusing on the phase 1A, which is related to healthcare workers and skilled nursing facilities. So all of our employees are on phase 1A, along with our physicians and along with our contracted services for the hospitals. We use the California Department of Public Health, along with Washoe County guidance for how we disperse that vaccine in our health system. As you know, every one of our health care workers is essential to us, and every individual will be offered the vaccine over time. We're not requiring the vaccine of anyone, but we do offer that. So because of the limited quantity that we receive, we first are offering the vaccine to our clinical and non-clinical staff who are at the highest risk of exposure in the hospitals. So that's Incline Village Community Hospital and Tahoe Forest Hospital, and also our respiratory illness clinics, both at Incline Village and Tahoe Forest Hospital, to receive the first round of vaccine. So again, those that touch COVID patients every day, or those that are at the highest risk in the hospitals and the respiratory illness clinic are being offered that vaccine. We have asked all of the staff to be patient for their opportunity to receive the vaccine. Again, just making sure we follow those guidelines, both from the state of California and the state of Nevada. I will say every day we hear new information from our counties on the allotment of the vaccine. And what we have learned over the last 2 to 3 weeks is we need to be very agile and very patient in moving forward in the vaccine process, not only for our hospital, but we will know as we move out into the community in the future, again, because not all information is as detailed as we would like it. So again, the focus right now is 1A. I know we are receiving a lot of questions from community members, but we have not really been giving those detailed guidelines yet on next steps. We have received the allotment for Tahoe Forest Hospital for the Pfizer vaccine, and we will be beginning that shortly and vaccinating our first group of Tahoe Forest Hospital individuals. Incline Village Community Hospital also has received their vaccine, and they actually have already started that vaccine process, working closely with Washoe County Public Health in the state of Nevada. So that's a sort of a brief but very high level on what's occurring with, again, the vaccine regarding to the different phases. And as I mentioned, we're in phase 1A. And I'd like to turn it over to Dr. Cole, our Chief Medical Officer, who will give you a little bit more information about the Pfizer vaccine. Thank you, Sean.
Thank you, Judy. So I hope you guys can hear me okay. We have 2 vaccines that are coming out back to back. One is the Pfizer, the other one's the Madrna. They're both mRNA vaccines. This is a new technology. They've never been licensed at this point for human use. However, the technology has been around since the early 2000s. The really awesome, cool part of this is that you cannot get COVID from this vaccine. That is key in this. A lot of people come in with misconceptions about certain vaccines. This one, you cannot actually get COVID illness from the vaccine. The vaccines are about 95% effective after the booster dose. So the first dose is not going to give you that high rate, but that second dose is going to make it so you're about 95% protected. It will also mean that if you do get COVID after getting this vaccine, that your rate of illness is going to be much lower. You will have a much lower incidence of needing hospitalization or any intensive care. That is key. This may not prevent you from getting COVID 100%, but it will dramatically reduce the chance of you getting super ill from it or needing hospitalization. One thing that can happen after you get the vaccine, and it tends to happen after the second vaccine, is you can have what we call an immune response. So you get a sore arm, you might feel achy, you might have a low-grade fever. This is not COVID. This is your immune response mounting a response to this vaccine, to the COVID, and protecting your body. So basically this mRNA, what it does is it's a short blueprint for the spike protein, which is, you guys have probably all seen the pictures of the ball with the spikes coming out of it. And what this is a short portion of the DNA from that particular protein. Now, the reason why we probably haven't used mRNA technology before is the biggest drag is that we have to store it in an ultra low temperature freezer, which makes the process of giving it very difficult. You go into the pharmacy or into your physician's office and you say, I'd like a flu vaccine, please. And they pull out a vial and they draw it up for you and you get it. However, with this vaccine, you have to dilute it. It has to be given within a certain amount of time. It has to be warm for 30 minutes. Like there's such a process that's going through. And however, when you're doing a mass vaccination process, you can schedule people closely together and make sure they're all vaccinated well. So that's why we're probably pulling out this technology, is because this is a mass vaccination effort. I want to give kudos to, the pharmacy, to facilities, to occupational health for all that they've done in order to make this process happen, to try and get all of these people vaccinated within a certain amount of time, watch them afterwards for 15 to 20 minutes to make sure there's not a reaction, all of that. Just the process of putting this together and implementing it has been huge. I'm excited to let you know that 7 a.m. tomorrow morning will be the first time at Tahoe Forest. And like Judy mentioned, Incline Village is already way ahead of us and has vaccinated quite a few individuals over there. The Madrna vaccine, which is the second one to come out. And actually, Ted, did you hear, did it get approved today through the FDA?
Yes.
Yeah.
Yes. Okay.
I think so.
We were anticipating approval. I've been so busy today, I didn't get a chance to check on that. The nice thing about the Madrna is it can be placed in a regular freezer instead of the ultra low. So that's very nice. There is a third vaccine that's coming out. This one's the AstraZeneca vaccine. It is not an mRNA technology. It's different. It's actually a transfected chimp adenovirus. And you can actually get COVID from this vaccine. It would be a light case of it, but that's the nice thing about the Pfizer and the Madrna, is that there's no way of actually getting it. I think the other big question that I keep hearing that I just wanted to let you know is, if you have had COVID, the question is, should you get the vaccine? And the answer is yes. The CDC put out a morbidity and mortality report in the end of November. They had looked at 152 healthcare workers, just because that happened to be the population that they looked at. Those healthcare workers had had a positive PCR test, which is the one that goes up the nose. They also had a positive antibody test, which is the blood test. And they then looked at antibodies at 60 days out, and 28% of those folks who had had positive antibodies no longer had antibodies anymore. So the recommendation is, if you have had COVID, you should still get the vaccine. However, during this time of shortage of vaccine, you could potentially wait up to 90 days from your initial onset of COVID, because you likely have good antibodies for that first 90 days and allow your colleagues or friends or family to get the vaccine first. But really, to be protected, you should have that vaccine within 90 days. So that's all I had prepared for you guys. Do you guys have questions that I may or may not be able to answer?
Yeah, yeah, everybody, thank you for your reports. Do they have any idea how long the benefit of the vaccine will last?
No, they don't. Hence the reason why I said I don't know if I'll be able to answer your questions. That they really do not know how long this vaccine will last, and whether it's something that will need to be done on a yearly basis, or if the boosters will need to be closer together than that or farther apart. They will be definitely watching it with the first cohort of patients that have received the vaccine.
Thank you.
So then, Dr. Cole, do you think that next year, a year from now, that we will be getting this vaccine again, because we don't know how long it lasts?
No, my assumption is that they're going to be checking that first vaccine group and figuring out in that first trial whether or not people continue to have antibodies at 6 months, 12 months, 3 years, 5 years from there. So it will really depend on what data comes out of that, whether or not we'll need to continue to get this vaccine or not.
And do you think it'll always be 2 injections?
For the first dose, absolutely. Typically, although this is a new technology, so we really have no idea, typically booster shots are not a 2-set series. It's usually a booster once every X amount of time, whatever that happens to be per that vaccine.
I just noticed this year that the shingles vaccine is now 2 injections. And I think they're 3 months apart, whereas previously they were only 1. So.
But the efficacy has greatly gone up too. I have a comment, if I could, and Ted, as a builder, you'll have an appreciation for this. When I was building custom homes, I used to say to my subcontractors, I can deal with good news. You're going to be here next week as scheduled. But I can also deal with bad news. You know, it's delayed. You won't be here for another 2 weeks. I find it really difficult to deal with no news. And I applaud the hospital for that press release that you put out the other day. I recognize that things are changing rapidly, and things that you might say today may be different a week from now or 2 days from now. But I think the best thing we can do to our community, for our community in this waiting interim period, is not to listen to just national news, but local news. What's going on here? And so to the extent that we can answer those questions that are in the back of everyone's mind, when am I going to get it? What's the likelihood? You know, I don't know about you, but in the grocery store line the other day, I had 2 people who knew I was on the board, and they asked me. I had questions at the Squaw Valley, in the locker room, skiing, and so forth. So these questions are on people's minds, and to the extent that we can alleviate any anxiety by keeping them informed, I urge you to consider continuing that.
Hey, Dale, thanks for that feedback. Not only did we do a press release, but we also sent a message out through MyChart to all of our patients that are on MyChart to get a message out. We've also put it on the website and asked them to continue to go to tfhd.com in order to get updates and any information. And as soon as we know something, we will let people know. I mean, this morning we were, well, I think yesterday we were supposed to get our vaccine on Friday, and then this morning we got it at 7 a.m. and we are so excited. I mean, things are just changing minute by minute, and we're rolling with it, and we're trying to give as much information as we can without leading the public in the wrong direction.
I think it's just the anxiety of the public that they want to know something. Mostly they want to know, when can we get through this and get out and move about as normal.
Yeah.
So that's why
you can always put a caveat on your information that you put out. This is the information as of today. We can't tell you what the likelihood is that it will change tomorrow or in a week from now, but this is the latest information that we have, subject to change.
Yeah, and you've done that, so that's fine. Michael?
Yeah, just a question around employees and the fact that it's a voluntary process. Moving forward, is there, I mean, employees that choose not to get the vaccine, are they limited in patients they can see? Do they have different protocols for how they operate, or is it everyone's treated the same whether you got the vaccine or not?
Yeah, everyone's treated the same. So I think what's super important to know is even if you get the vaccine, using your proper PPE or your protective equipment is key. You have to remember it's 95%. So if you're that 5%, it's 100% for you. So you need to, we all need to continue to be extremely diligent, especially at this point, and probably for at least, my prediction is at least another year. Dr. Fossey from the infection control specialist for the nation basically also concurred that he believes that we will still be masked for probably until this time next year.
Director Wong, I also just wanted to mention that, you know, weekly we are working with Placer County, Nevada County, and Washoe County on the vaccine process. And even just today, we met with Placer County, and I talked yesterday with Nevada. You know, we feel like we are moving forward with the phase 1A. So now it is time to move to phase 1B. And so though we haven't necessarily started all of our injections here at Tahoe Forest, we are already looking to the future on our future phases and how we're going to meet the needs of our both Placer County Nevada County and Washoe County communities.
Thanks, Judy. Okay. If there aren't any other comments, and thank you again, all of you, for your update and keeping our community informed of where we are with the vaccines, where we are with testing, where we are with everything that relates to COVID. We'll
there
move
may be
on.
some public comment for this one.
Oh. Do I have any
Is there any
public comment? Okay, hearing none. We didn't pull anything from the consent calendar, so we'll move on to 19. This is the board officer elections, and I'm going to turn this over to Ted, our governance executive director. And also, I think Martina is going to be involved in this as well.
We will. Thank you, Chair Wong, directors. This is the time of year where we elect our board of officers for the ensuing year. Ordinarily, you have two paths before you, I would suggest tonight. The typical path, this is for Director McGarry, we've not been through this before. It would be typical for the ask for a nomination of the board chair position. And there would be, and then after that has been decided, there would be subsequent nominations for the other officer roles, that of vice chair, treasurer, and secretary. There's not a requirement for a second, I believe, David, on a nomination. You can go straight to the vote. That's a typical board selection process. We also have in our bylaws, this is also for Director McGarry, the allowance for the board chair to serve consecutive terms as long as there's a nomination as such, and as long as it's unanimous. And that would include the board chair being part of the unanimous vote. Sometimes the board may rotate. The other opportunity I think that the board has tonight as an option, largely driven by COVID and the fact that it more or less froze us in a moment in time, and that we didn't function as we ordinarily would with retreats, and working closely with the leadership team to develop a strategic plan and the other activities that the board ordinarily engages in, might be to put forth a motion that the officers, everyone stay in the roles that they're in, and then move forward for the next year. That is certainly an option. That is up to the board. This evening, we will turn to Martina, the board clerk, to call for the nomination for chair, and or if there is a desire to make a motion that everyone stay in their position, that's certainly an option before the board. I did check with Mr. Ruderman earlier today. I think we are clear that a motion would be okay if it's all encompassing. You think it's an appropriate thing to do rather than go through the iterations of nominations?
Yeah, I do believe that's correct. I do think it would have to be unanimous though, because of the rule regarding the
that's right,
board chair.
So those are the two options I think that are before you. I can tell you that some other entities, that I'm involved in have just kept everybody in the same position. On the other hand, the town council just rotated and selected a new mayor. So the choice is yours. And I will turn it over to the board clerk, Martina Rochefort, to carry us forward from here.
Sure. Are there any nominations for board chair, or is there a motion on the table that officers would remain in their current roles?
This is Art. I liked everything you said, Ted, and I agree with what you said. I would like to make the motion that all officers stay in their current position for 2021. I think it would best serve the entire hospital and our board. So that would be my motion.
Second.
So we have a motion made by Director King and a second by Director Brown, and I will do a roll call vote to be sure that it's unanimous. Director McGarry.
Aye.
Director Shamblin.
Aye.
Director King.
Aye.
Director Brown.
Aye.
And Director Wong.
Aye.
Thank you.
What about the committee assignments? Would those change or?
Committee assignments are still something that you will work out with the board chair.
And as we did in the past, is that an email will come out asking preferences. And if we can, if you would like to stay on the committee, that's great. If people want to change, we can also do that. And that'll come out later this month or before our next meeting. At our January meeting, the committees are to be assigned. And also the committees will have the responsibility to review their charter to make sure that it's current and accurate.
Okay.
So I guess I'll continue chairing the meeting.
Yay, way to go.
Yeah. Do I have any board committees that met in December? I guess not. Are there any board reports that need to be given?
Yeah, I have one. Yesterday, Chair Wong and I met with Harry Weiss to go over his annual evaluation, CEO evaluation. It's a long process. It took a few months to go through. We got a lot of good information. David put together a very nice memo, and I'm pleased to say we had a really nice meeting yesterday. It's really easy when the evaluation is so good. And so, Harry's done a great job, and I just wanted to report on that. We're lucky to have him as our CEO.
Thank you, Art. And thank you, Harry, for the time that you gave us to go over the evaluation with you and your openness to listening to what we were saying and actually taking notes on some ideas that you were getting as we spoke. I do want to shout out to David, who took all of our information, all of our chatting, and put it in a very concise, excellent narrative, letting the CEO know where he was with his performance as the board saw it. So thank you again for that, David.
And really, Harry only cried once or twice yesterday, so it was a good meeting.
Okay, any closing remarks from our board?
It's the end of a year. It's been an interesting year. So, I'm looking forward to having face-to-face meetings again, hopefully sooner than later. And Michael, I don't know, you had one, I guess, didn't you?
Yeah, my first and only.
First meeting. Yeah. So I'm really looking forward to that.
Yeah. And Michael, we're really glad that you accepted being on the slate of officers, being on the slate of officers, because you don't even know who we were, really. You met us once in person, but thank you for staying and being a trooper about that. And I want to thank all of the staff, all of the administrative council, all of the directors who have come and shared information with the board as far as what's going on in our district, what's going on in our hospital, what's happening with our physicians, what's happening with our employees. I think that it has been a very collaborative and effective year that we've had. And where's our Crystal Betts? Crystal, and thank you for those reports and keeping us so financially stable. We appreciate all that you do. And so I've waited every year to say this, unless someone has something else to say. Happy holidays to all, and to all a good night. The meeting's adjourned.